Next question. 2.5 centimeter cystic mass in the tail of the pancreas, has an EUS with a cyst fluid aspiration. Which is the most consistent finding for a mucinous cystic neoplasm, or a mucinous neoplasm in general, I should say? Yeah, good job, everyone. So elevated CEA in the cyst fluid is what you would expect in a mucinous cyst. And let's do another quick question. 67-year-old man has a Whipple for main duct IPMN. We'll talk about what that means later. You send some frozens. You get back the result. The pathologist says, oh, it's Panin 3. I should say we actually don't call it Panin 3 anymore. We call it just high-grade dysplasia. They say, oh, this high-grade dysplasia or Panin 3. And what do you want to do? Do you want to just do a total pancreatectomy, remove everything? Do you want to just do your anastomosis, whatever you chose, a PJ or PG, and then just follow the patient? Do you want to re-resect and then send another frozen margin? Or do you want to finish the job, just sew it up, do the PG or PJ, and then give them chemotherapy afterwards?
Okay, results are out right now. Yeah.
Okay, I'm disappointed you guys know. So the answer with high-grade dysplasia in the context of the main duct IPMN should be to re-resect. You're going to have to revise that margin. A total pancreatectomy is not unreasonable in very highly selected patients, and we can talk about that some more. So mucinous cysts come in different flavors. There's the mucinous cystic neoplasms and the IPMNs, and then the IPMNs themselves come in different subtypes: main duct, branch type, or branch duct, and mixed main duct and branch type. The mucinous cystic neoplasms do not communicate with the pancreatic duct, and they have an unknown but thought to be high risk of cancer, thought to be over 10, at least 10%, possibly even more, and the indication is for them to be resected. The IPMNs come on a wide spectrum of biological behavior, from a lifetime risk of malignancy of about 10% for most branch duct IPMNs to a lifetime malignancy risk of about 60% for main duct IPMNs. And that variation in the life history guides the surgical treatment, from surveillance for most branch duct IPMNs to resections for main duct IPMNs. Mucinous cystic neoplasms are defined by the presence of an ovarian-like stroma. That's very often asked on exams, and that is the pathognomonic finding of the MCNs that distinguish them from other cystic entities. They do not communicate with the pancreatic duct, unlike the IPMNs, which do. They have a female predominance, and again, we think that the risk of cancer is certainly at least 10%, probably more. And resection is recommended. These patients typically present quite young, in their 30s, 40s, 50s. Main duct IPMN is a diffuse dilatation of the main pancreatic duct without an obvious cause, and I think that's the main. Point here, is that it's not someone who has chronic pancreatitis, who has a stricture and who has a dilatation of the pancreatic duct. It's someone who has no other reason to have a dilatation of the pancreatic duct. The risk of malignancy is high. In the early Japanese series, it was 80% or more for the presence of malignancy defined as high-grade dysplasia or invasive cancer. The true number is probably a little bit lower, around 60%, and obviously lower for invasive cancer. So we say 60% of malignancy, including high-grade dysplasia and invasive cancer. And then the surgery that you're going to design for these patients, because surgery is indicated for everyone with a main duct IPMN, depends on the location of the cyst. And certainly if you have a localized cyst, the cyst is mostly in the head of the pancreas or mostly in the tail of the pancreas, the choice is easy. If you have a cyst that is diffuse, then it's a bit more of a clinical dilemma. Once you've made sure that there are no enhancing nodules anywhere in that will make you change your mind, the approach that most people would take is to do a Whipple, check the margin, send it for a frozen, and then extend that more and more and more if you find high-grade dysplasia. The reason we don't do a distal is because if you do a distal and you find a positive margin of high-grade dysplasia, you can't keep taking more pancreas, right, if you're in the head of the pancreas already. The role of a total pancreatectomy is more controversial. It may be a reasonable option for highly functional, young patients that are extremely healthcare literate, that can essentially learn how to manage a very brittle diabetes, because that is essentially what you're committing this patient to, is a lifetime of a very brittle diabetes that is very difficult to control. And a significant number of patients will die from brittle diabetes, significant hyperglycemia and hypoglycemia in that context. So you're going to be very selective about who you offer a total pancreatectomy to. Mixed duct IPMN has both features of a branch duct IPMN and a main duct IPMN. You're going to manage them the way that you do a main duct IPMN, essentially. The risk of malignancy is driven by the main duct component. Let's talk a little bit about branch duct IPMNs. You have a 69-year-old male with a 3.5 centimeter cyst in the pancreatic body for a CT scan done for an unrelated reason. The cyst has a thin septation and appears to be communicating with the main pancreatic duct. The presentation was pancreatitis. That's why they had the CT scan. What is the best management for this patient? Do you do a distal pancreatectomy? Do you observe them? Do you do an endoscopic cyst gastrectomy? Or do you enucleate that cyst? All right, most people want to observe. The answer is actually a distal pancreatectomy, and we'll talk about why. Observation is not wrong, but this patient has essentially two worrisome features now. They have a cyst that's over 3 centimeters, and they have a presentation with acute pancreatitis. We'll go over what a worrisome feature is and what a high-risk feature is when we're dealing with branch duct IPMNs. So in side branch IPMN or branch duct IPMNs, if you have a high-risk stigma, you're going to surgery right away. So that's patients who come in with obstructive jaundice, an enhancing mural nodule of over 5 millimeters, a main pancreatic duct that is quite dilated over a centimeter. Then you have worrisome features, some of which are clinical and some of which are biochemical or radiological. An elevated serum CA19-9, a cyst of more than 3 centimeters, enhancing cyst walls, or a enhancing nodule of less than 5 millimeters. A duct that isn't quite a centimeter, but that is dilated 5 to 9 millimeters, and a cyst that is growing 5 millimeters in more than 2 years. And these are issued in the revised Fukuoka guidelines, which are the guidelines that most surgeons are using and that should be using. There are other guidelines that are issued by gastroenterologists that we're not going to get into it now, but have their own problems. So this really is a slide that should be imprinted in your minds as you prepare for your exams and in your future practice. If anyone has a high-risk stigmata, they go to surgery if they can have surgery. If they don't, then you ask yourself, do they have any worrisome features? And if they have any worrisome features, then you want to stage them somehow. So an endoscopic ultrasound, and then if the endoscopic ultrasound, based on the findings of the ultrasound, you're surveying them at different kind of time intervals. But then the more worrisome factors you have, and the more that's going to start skewing you towards surgery. So it's not wrong to take someone with 2 worrisome factors to the operating room. And you'll note that it says that for young, fit patients who have a cyst of more than 3 centimeters, it may be reasonable to simply consider surgery as a way essentially of sparing them what otherwise would be an MRI and EUS alternating every 3 to 6 months for the rest of their life. And obviously that depends also on the location of the cyst. A Whipple and a distal pancreatectomy have a very different morbidity profile. So you're going to be selecting your patients from that perspective. There's 4 subtypes of IPMN histologically. There's a gastric subtype, an intestinal subtype, an oncocytic subtype, and a pancreaticobiliary one. The pancreaticobiliary one leads to when it transforms, leads to the cancer with the most aggressive behavior. And the oncocytic subtype is the one that most commonly leads to a cancer. The gastric subtype is your kind of garden variety IPMN, usually low grade and has a low risk of malignant transformation. You won't usually know this before the OR, that's the final pathology. And when they do transform, usually there's the ones that have intestinal transformation with an intestinal subtype, and then there's the pancreaticobiliary subtypes, which have a worse prognosis. And again, you won't know this before you take this patient to the operating room. So the summary slide, we talked a little bit about pseudocysts earlier on. serous cystic neoplasms and mucinous cystic neoplasms are female predominant. IPMN are not. You can kind of see the variations of, cyst biochemical analysis and how that helps you kind of navigate the differential diagnosis and the implications. Any questions before we move on to malignant entities? Okay, we have about 20 minutes left. So we'll be talking about malignant lesions of the pancreas for most of the rest of the time. We'll divide them into primary lesions and metastatic lesions. Primary lesions, you'll have adenocarcinomas, which arise from the acini and the ductal systems, neuroendocrine tumors, solid pseudopapillary neoplasms, and then in the metastatic realm, we'll be touching very briefly on some of the ones for which there is an indication for resection. Voilà, donc the same thing. A 32-year-old female who had a Whipple for a 12-centimeter tumor. The pathology reveals a solid pseudopapillary tumor with negative surgical margins and negative lymph nodes. What should follow surgical resection in this patient? Surveillance CT scan in a year. Good job. Okay, let's talk about spins a little bit. They're also known as Franz tumor or Hamoudi tumors. It took me quite a while to figure out who Hamoudi was. I thought he must be a brother or something, but he's actually from Ohio. So he's not from the Arab world. And he's not a surgeon. He's from what I could gather, like a pediatric pathologist. They're rare, pancreatic neoplasms, typically asymptomatic, but they do have a malignant and metastatic potential, and they have to be treated as such. They are pseudopapillary because they don't contain real papilla. The papilla are essentially fronds of necrotic tissue within the tumor. They present in young women, usually age 27, and they can appear cystic on imaging, as I said, because of that necrotic central core that gives these pseudopapillae. And typical appearance, as you see on the CT scan, has the 4 Cs. They're circumscribed, they're cystic appearing, they're not real cysts. They're not a pseudocyst, but they're not real cysts. They have a firm capsule and they can have internal calcifications as well. And the indication for an SPN, the treatment is a surgical resection. Even with an R0 resection, there's a relatively high rate of recurrence, both locally and metastatically. But even in the metastatic setting, the indication is that we should be fairly aggressive pursuing even metastatic disease in these patients. In patients that are unresectable for a variety of reasons, then there are some systemic options that are not curative, but that are palliative. Let's talk a little bit about pancreatic lymphoma. This is something that you'll see every now and then. It's a rare entity, but it's something that you'll suspect when you have a bulky lesion with a really dramatic amount of local lymphadenopathy, but without some of the hallmarks of pancreatic adenocarcinoma, such as jaundice or pancreatic ductal dilatation. And there really, your role as a surgeon is going to be diagnosis and then referring this patient on. You usually need a core biopsy to establish the diagnosis because you need some cytoarchitecture. Okay, 55-year-old male has hypoglycemia as a presenting symptom. He has a 1.5 centimeter insulinoma in the head of the pancreas. And on the MRI, he has a single lesion in the liver in segment 3, consistent with the metastases. So he has a metastatic insulinoma. What do? Do you enucleate the pancreatic lesion? Do you just treat him symptomatically with octreotide and acarbose? You do Whipple and a liver resection, or do you just core out both of them? You core out the pancreas and you core out the liver lesion. Whipple and liver resection. Good job. We'll talk a little bit about pancreatic neuroendocrine tumors. These are a very heterogeneous group of tumors that come in a wide spectrum of biological behavior and malignant behavior. They do have the potential to secrete either hormones or hormonally active substances. And insulinoma makes insulin, the gastrinoma makes gastrin, glucagonoma makes glucagon, et cetera, et cetera. And they secrete a variety of other ones, even the ones that are not insulinomas, gastrinomas, or glucagonomas, can secrete a pancreatic polypeptide, chromogranin A, ghrelin, calcitonin, etc. They are rare, and most of the pancreatic neoplasms that you'll see in your career are pancreatic adenocarcinomas. As you said, they can be functional or non-functional. Most of them are non-functional. They either do not produce any hormones or only produce them at lower levels, such that the patient is asymptomatic from that perspective. The incidence is increasing, probably related to increasing cross-sectional imaging. Insulinomas and gastrinomas are the most common, and insulinomas are typically benign ones. The incidence of a malignant insulinoma is low. It's less than 10%. It's quite rare. I mean, there is one in that scenario to kind of throw you off, but that's essentially right. Gastrinomas are much more likely to be malignant. So are glucagonomas. Glucagonomas tend to be associated with a very specific idiosyncratic rash that's called necrolytic migratory erythema migrans, or necrolytic migratory erythema. Vipioma and somatostatinoma are characterized by profuse watery diarrhea with electrolyte abnormalities. Chromogranin A is a biochemical marker, but we don't use it as a diagnostic tool or as a screening tool. It can be used to track, essentially, response to treatment. You can get a CT scan, but it's important that if you do, that it's in the arterial phase, because these are arterially enhancing tumors and you can easily miss them on a portovenous phase. MRI may be a bit more sensitive in terms of the resolution, but certainly the most sensitive test for neuroendocrine tumors is a gallium dotatate. The advantage of the gallium dotatate is that it also gives you information regarding the somatostatin receptor status of the specific tumor, potentially opening up treatment avenues for targeted therapy regarding PRRT later on. There's really no role for a PET scan except for the most dedifferentiated tumor, which are not really neuroendocrine tumors. They're really neuroendocrine carcinomas, essentially, or neuroendocrine, very poorly differentiated neuroendocrine carcinomas, NECs, not NETs. There's a WHO classification that uses the Ki-67 as the chief predictor of biological behavior. When a tumor has a low Ki-67 and a low size, so you have a tumor that is less than 1 centimeter with a Ki-67 less than 2%, the risk of lymph node positivity in a tumor like that is quite low. It's not zero, but it's about 5%. If you have a tumor that's over 2 centimeters, especially if the Ki-67 starts to rise, then the incidence of lymph nodal metastases starts to rise, and it's 15% and more. And that's where we start intervening on these tumors. So we tend not to intervene on small tumors with low Ki-67 indexes that are well differentiated. We do tend to intervene on larger tumors that have higher Ki-67s. A 37-year-old man with a history of hyperparathyroidism presents with abdominal pain. He gets a CT scan that shows 3 hyperenhancing lesions in the pancreas. What should be his management? They're all under 2 centimeters, essentially. Oh, total pancreatectomy. But guys, we just said that total pancreatectomies are like a very morbid thing, and you want to try not to do it. But no, the answer is actually that you're just going to watch it. It's not C, sorry. You're just going to watch this patient. MRI pancreas in 3 months. This patient has a multifocal process. If you just remove the largest lesions, you're still going to watch the rest. And as we said, when they're under 2 centimeters, especially if you have a good idea that these are low, well-differentiated tumors, you're just going to watch them. Surgery is the only curative treatment for neuroendocrine tumors. But the flip side of that is that very few patients are actually cured by surgery, especially if they already have metastatic disease and if they're node positive. in order for you to do a formal resection of a neuroendocrine tumor, you need to perform a lymphadenectomy. If you're removing it, you're presumably removing it because you're concerned about its malignant potential and you need to get the lymph nodes out. So indications for enucleations has really dropped. In order for you to be able to enucleate a lesion, it has to be away from the pancreatic duct, which typically means that it's going to be in the tail and very exophytic. If you have one in the head, it's unlikely that you're going to be able to just core it out unless you knew with good certainty that it's away from the pancreatic duct. And it has to be small. But the flip side of that is, well, why are you removing it in the first place? If you're removing it, it's because you're concerned about it. And if you're concerned about it, you should get the lymph nodes and do a formal resection. If you are not concerned about it, then you should be simply surveilling it, and therefore enucleating it simply exposes the patient to a risk of pancreatic fistula without any of the oncological benefits. You're still going to be surveilling this patient anyways. So enucleation is quite controversial and limited to small insulinomas and hormonally active neuroendocrine tumors that are away from the duct again. Voilà. So, and you should consider observation for incidental, small, well-differentiated neuroendocrine tumors. You have neuroendocrine tumors that are under 2 centimeters. Certainly, if they're under 1 centimeter, you can watch them without a biopsy. Between 1 and 2 centimeters, most of us would get a biopsy of them to make sure that they're not poorly differentiated or have a high Ki-67 before we commit them to a course of clinical observation. Because again, the likelihood of them being malignant is pretty low. Well, that's about it for neuroendocrine tumors, and we can address that more if you have any questions about that later on. Keep in mind that that's different from neuroendocrine carcinomas, which are poorly differentiated tumors that you should really think of as small cell tumors, kind of like small cell tumors of the lung. They have a very poor prognosis. Surgery is not first line for them. They should just get systemic chemotherapy. That's how you manage patients with neuroendocrine carcinomas. There are some targeted therapies for patients who are not surgically resectable. These include somatostatin analogs, which do slow progression and prolong progression-free survival on multiple randomized trials. So these patients, if they have widely metastatic disease that is not resectable, they are usually on long-acting octreotide analogs. Conventional chemotherapy using everolimus or temozolomide is also going to be considered for specific patients, specifically based on their differentiation. There are also targeted therapies that use lutetium that is chelated with an octreotide analog to essentially target the tumors with radiotherapy, and there is a much higher response rate than just with systemic therapy with octreotide analogs. This was demonstrated in the NETTER-1 study, and that is one of the benefits of having a dotatate scan. If you can demonstrate that the patients are somatostatin receptor positive, they have widely metastatic disease, they will benefit from PRRT. Well, so some patients will end up getting streptozocin or temozolomide based on the specific situation. Okay, let's move on and talk about pancreas cancer proper. What's the strongest risk factor for pancreas cancer? Is it smoking, age, chronic pancreatitis, family history, or asbestos? Yeah, so it's age. So when you consider that chronic pancreatitis is a rare diagnosis in the general population, but that pancreas cancer is still a relatively common cancer, age rises to the fore. In terms of environmental exposure, smoking is a known risk factor, but most patients with pancreas cancer you'll find are non-smokers. Which of the following is incorrect regarding pancreas cancer? Majority of patients have unresectable disease. The most frequent presentation is painless jaundice. Involvement of the SMV is a poor prognostic marker. Median age of diagnosis 6 to 7 decades, and survival 2 years beyond diagnosis is rare. So this is asking what is incorrect. And it is actually incorrect that the SMV involvement is a negative prognostic marker. It is very much correct that survival beyond 2 years is rare. Very few patients with pancreas cancer survive beyond 2 years. It's the fourth leading cause of cancer death. Most common presentation is jaundice. And the 5-year survival is dismal at 8% for all incomers for a variety of reasons, which we'll explore. That's a question that is often asked on exams, and we don't have to bring up the poll. We'll just kind of go through it. The hereditary condition that has the highest risk of developing pancreatic carcinoma is Peutz-Jeghers. All of the other ones do have an increased association, including PRSS1, which is predisposed you to chronic pancreatitis, BRCA2, which predisposes you to pancreas cancer, along with breast cancer and ovarian cancer, and hereditary non-polyposis, which also has an increased risk of pancreatitis. But the one that really has the highest risk is Peutz-Jeghers. It increases your odds of developing pancreas cancer by 100. Let's talk a little bit about resectability for pancreas cancer. The definition of borderline resectability used to be pretty much in the eye of the beholder. Some surgeons would look at a scan and say, oh, I can do this. And others would say, I don't think we should do this. There have been multiple, sometimes competing definitions of what a borderline resectable cancer is. Really, the definition that you should know, the one that is used in most clinical trials right now and that has emerged at the fore, and to which all the other definitions have converged, is the intergroup trial definition, which basically says that if there is any contact with the SMA of less than 180 degrees, that patient is borderline resectable. Meaning that if they have interface of more than 180 degrees, they're locally advanced and unresectable. If they have interface with the celiac artery as well of less than 180 degrees, they're unresectable. More than 180 degrees, they are borderline resectable. You can reconstruct short segments of the common hepatic artery, and that's still borderline resectable, not unresectable. And for the purposes of the SMV and the PV, it almost doesn't matter exactly how much of it is involved, even if it's more than 180 degrees. If it is a reconstructable defect in the vein, then that is considered borderline resectable. So you have an 82-year-old man coming into the emergency room with painless jaundice. They're otherwise healthy. Their ultrasound demonstrates a dilated common bile duct and a 2-centimeter mass in the pancreatic head. What is the next step in management? Should they get an ERCP, brush their duct and put a stent, a PTBD to decompress their bile ducts? Should they just go ahead and get a Whipple? Should they get a CT scan first? Should they get some palliative chemotherapy? All right, so we have a split. Half of people want to get a CT first, and half people want to get an ERCP first. And the answer is a CT scan. You want to stage this person fully, but you also want to stage them before you do the CT scan and put a stent there and disrupt the local anatomy. It is much easier to appreciate arterial involvement and local anatomical involvement before the CT, before an ERCP, before you have a metal stent there, and some of the artifact that comes with that. And complicating things even more, if that patient develops pancreatitis from your ERCP, then you won't know what changes, and you do the CT scan after, you won't really know what's cancer and what's inflammation. So you want to stage them first, get the ERCP after. There's no urgency for the ERCP, right? Patients that come in with obstructive jaundice from a malignancy are not cholangitic. They don't have cholangitis. There's no urgency to get the CT scan, to get the ERCP. Get your CT scan, stage them, and then you can get the ERCP and the stent later. We won't need to bring up the poll necessarily, but essentially that's to drive home the point that the CA19-9 is not a diagnostic test. It is not a screening test. It is a test that helps you define response to treatment and gives you an early signal perhaps for early recurrence in the future as you're surveilling this patient after their surgery. So surveillance for recurrence post-surgical resection is where you're going to use that CA19-9 essentially. CA19-9 is the tumor marker for pancreas cancer. It's not recommended for screening. It is not very specific. A bunch of other things will give you an elevation in your CA19-9, including obstructive jaundice or any manipulation of your biliary tree. These patients with pancreas cancer needs to be staged, and the staging modality is a CT scan. you got to get the CT scan in a pancreas protocol. So you need an arterial phase to define arterial involvement, a portovenous phase, and then a delayed phase as well. PET scan does not have, there's no role for a routine PET scan. You can get a PET scan to elucidate specific lesions where you're not sure if there are distant metastases or not. And then endoscopic ultrasound is extremely useful. It allows you to get a biopsy in a way that isn't too invasive and certainly less morbid than a percutaneous biopsy. And both the FNAs are pretty sensitive, but a core biopsy is even more sensitive for picking up pancreas cancer. The role of preoperative biliary drainage is a bit controversial. There's no benefit for routine preoperative drainage. So it's not everyone who has a pancreas head cancer that is jaundiced, that is awaiting a Whipple, that needs a biliary stent. The minute that you put a stent in, you've now colonized their biliary tree, and there's a thought that that increases septic complications and wound infections in the postoperative period. This was demonstrated in a randomized trial. That's not definitive word on that. There's lots of problems with that randomized trial. It included patients that were the least likely to benefit from stenting because it didn't include any patients that were very, very jaundiced. But the thought right now is that you don't have to stent everyone. If you're able to take this patient to the operating room pretty rapidly and they're not terribly jaundiced, so their bilirubin is less than 250, in our units, I'm not sure what that corresponds to in your units. I think you have to divide them by 1.9. Essentially, you can take that patient to the operating room. If they're not terribly jaundiced, you can get to the OR pretty quickly. You don't have to stent them pre-op. Okay, let's talk a little bit about diagnostic laparoscopies. In which of the following scenario is a diagnostic laparoscopy the most appropriate? A 2.5 centimeter mass in the tail of the pancreas and no distant metastases on CT. A patient with a 4 centimeter solid mass in the head, which encases the celiac axis. 2.3 centimeter mass in the pancreatic head with abutment of the SMV and distant metastases, and no distant metastases. And a patient with a mass in the pancreatic body and they have ascites. Where is a diagnostic laparoscopy the most indicated? Yeah. So that patient with abutment of the SMV and no distant metastases is probably gonna get chemotherapy up front. They have a borderline resectable cancer. They're probably gonna get chemotherapy up front. For B, in case of the celiac axis, that patient's not gonna be operated on anyways. So they're just gonna get chemotherapy. Patient with the ascites, you can just tap the ascites, and usually that's demonstrating to you that that patient has peritoneal carcinomatosis, so you don't need a diagnostic laparoscopy there. And the patient with the pancreatic tail mass, that's the one that probably benefits the most from the diagnostic laparoscopy. You can certainly do that at the time of your surgery or do it separately. The diagnostic laparoscopy saves you a large incision if a metastatic disease is found. Historically, people used to just do an operative bypass anyways, and so they would just start open. But now that we're not bypassing people surgically quite as much because the RCPs are quite good and you can stent the duodenum, then there's certainly an incentive to avoid a large laparotomy that would delay them from getting chemotherapy. So on the large meta-analysis, you avoid about 23% of the non-therapeutic laparotomies, just over getting a CT scan. Let's talk a little bit about neoadjuvant chemotherapy. Potential advantages are higher likelihood of completing chemotherapy pre-op versus post-op. And that's because after a Whipple, there's all the digestive issues, you're still recovering from surgery, you're now expected to get more chemotherapy, and the ability to complete the cycles is compromised post-operatively versus pre-operatively. It offers a test of disease biology, but more importantly for us as surgeons, it really gives us a higher likelihood of achieving an R0 margin, which is really the only modifiable risk factor from the perspective of the surgeon. The disadvantage is that it may delay surgery, perhaps to the point where the patient would have progressed on chemotherapy. We may have missed a small window of opportunity. And that's a bit controversial, is that if that's really a disadvantage or just demonstrating to you that there is a patient that would not have benefited from surgery because they would have progressed anyways. There's also a certain deterioration in their functional status. So some patients will have such a severe toxicity from chemotherapy that they may stop being candidates for surgery, just in terms of decompensating their functional status. Question 15. The incidence of pancreatic leak following pancreatic adenectomy is the highest for which of the following indications? So this is asking where the incidence of anastomotic leak is the highest, not the lowest. And it's actually the highest for duodenal cancer. So for anything that is not a pancreatic pathology. And we'll explore that a little bit more. And we don't need to bring that up as a question, but essentially that's the converse. What indication or what factor decreases the risk of a pancreatic leak? And that's a history of chronic pancreatitis. We'll talk about that in a bit more detail. Pancreatic fistula is the leading cause of morbidity and mortality after pancreatic duodenectomy, and there's no single technique of pancreatic enteric reconstruction that has been found to be superior in terms of the incidence or the severity of pancreatic fistula. So whether you do a pancreatic gastrostomy or a pancreatic jejunectomy has never really been shown to be beneficial one way or another. People have investigated the role of stenting the pancreatic duct, and there's really no role for stenting the pancreatic duct unless you're going to actually sterilize that duct. Essentially, you're committing that patient to a cutaneous pancreatic fistula, a controlled one, but a fistula nonetheless. And octreotide itself does not prevent the pancreatic fistulas. There's some evidence that pasireotide in a single institution randomized trial did decrease the incidence of clinically relevant pancreatic fistula, but that has never been replicated in other institutions. The fistula risk score is a good idea for you to try and understand what the risk of your patient developing a pancreatic fistula is. The firmer the gland and the better it will take your sutures, and the lower the likelihood that it's going to leak. And you typically have a firm gland when you have a pancreatic cancer or chronic pancreatitis as an indication. And so conversely, an indication for the Whipple of pancreatic adenocarcinoma or pancreatitis gives you the lowest risk of a leak. These patients tend not to leak from their pancreas because they have a very atrophic, scarred pancreas with a large duct that anastomosis is pretty solid. Whereas if you're operating for another cause, they have a duodenal cancer, but their pancreas is actually completely normal, or they have an ampullary cancer, or they have a neuroendocrine tumor, their pancreas is completely normal. The pancreatic duct is very small, the pancreatic texture is very soft, and that patient is going to leak. Pancreatic duct diameter is also a corollary of that. The bigger the duct, the less they leak. The smaller the duct, the more likely they are to have a fistula and intraoperative blood loss. So you calculate these in what's called the fistula risk score. That is probably the most commonly used predictive score to predict the incidence of pancreatic fistula. The definition of pancreatic fistula in terms of clinical severity has changed. It's just been revised in 2016. And essentially, we divide them into clinically irrelevant pancreatic fistula. So just having amylase-rich fluid coming out of the drain does not mean that there's a clinically relevant fistula. And then there's grade B and C fistulas, where the fistula is engendering a change in the clinical management, whether that's by placing or repositioning drains by IR, reoperating on the patient, organ injury, et cetera, et cetera. Whether the surgical bed should be routinely drained or not has been a little bit controversial, more so for the distal pancreatectomies than for the Whipples. In 2014, there was a randomized trial that attempted not to place drains in a Whipple, and the study had to be stopped early due to increased morbidity and mortality in the arm that was not drained. And so there's probably evidence, most of us think this is evidence of harm when you withhold drain placement in a Whipple. That being said, is it possible that it is safe in some subpopulations, perhaps populations that have a really low calculated fistula risk score? We simply don't know, but I would say that the practice for most pancreatic surgeons is to universally place a drain after a Whipple. For a distal pancreatectomy, you could omit the drain. There is a randomized trial that suggests that drainage actually increases fistula rate, probably by demonstrating to you the incidence of many fistulas that would have been otherwise clinically irrelevant. the way that we manage these drains is by these fistulas is by draining them. If they've not been drained preoperatively, or if the drain is not doing a good enough job, then you may want to reposition another drain by interventional radiology. Reoperation is a last resort for these patients. And even when you're reoperating, you're typically there to place drains. You're not going to revise that anastomosis. You're not going to do anything fancy like that. Reoperating on these patients is extremely morbid and has a very high mortality. So it's excessively rare that we have to reoperate on a Whipple from the perspective of pancreatic fistula. And whenever we do, it's typically only to open, wash out, put drains, and close, if IR could not place the drains on your behalf. Surgery. I was asked to give a little thing about different kinds of surgery for pancreas cancer. Essentially, when it comes to pancreas cancer surgery, location tells you what you're going to need to do. Location with regards to the vessels, location with regards to where it is in the gland dictates what kind of surgery they're getting. So you have a tumor in the head that is away from the portal vein, the SMA, the celiac axis. You're going to do a Whipple. Whipple, you all know now, is resection of the head of the pancreas to the level of the SNV and portal vein, the distal bile duct, the gallbladder, the duodenum, the proximal vitrinum. And you can resect that with or without the pylorus. It does not really matter in terms of the outcomes. There was a belief at some point that pylorus preservation decreases the incidence of gastric gastroparesis or delayed gastric emptying. It does not. Its opponents say that it increases it. It doesn't increase it either. It's an exercise in style, really. If the tumor is on the portal vein, then you can do a Whipple with a portal vein resection, either a primary reconstruction or with a conduit. We won't get into too much details there. If the tumor is a bit more further out in the neck of the pancreas, then you can do a Whipple at the level of the splenic artery. So a Whipple where the transection line is not just over the portal vein, but is a bit more distal to that. If the tumor is in the body of the pancreas involving the splenic artery or the celiac axis, you could consider doing a distal pancreatectomy with a celiac axis reconstruction. But we won't get into the details of how to decide whether that's okay to do or not. That's kind of fellowship level discussions. If it's in the tail of the pancreas, you're going to do a distal pancreatectomy. And if it's an adenocarcinoma, you're going to consider doing a RAMPS, where essentially you are removing the perirenal fascia, the anterior renal fascia, so the gerota, possibly removing the adrenal as well, to make sure that you're clearing your margin posteriorly on the retroperitoneum. The role of arterial resections for borderline resectable pancreas cancer is very controversial. Even though removing the vein removing and reconstruction of the vein has minimal impact on morbidity, arterial reconstruction has a significant impact on morbidity. In terms of hemorrhagic complications, because now you have an arterial reconstruction next to a leaking gland that's secreting pancreatic enzymes on it. A lot of these patients will succumb to a pancreatic pseudoaneurysm. And we talked a little bit about pancreatic pseudoaneurysm. We were talking about acute pancreatitis and the sequelae of acute pancreatitis, but you can certainly have those as well in the postoperative period after a Whipple. And the typical scenario there is you have a patient who has a pancreatic fistula, maybe they're day 14 or day 18, and they suddenly have a little bit of blood in the drain, and maybe you get a call, the nurse calls you and says, oh, there's a little bit of blood in the drain. You say, oh, it's fine. It's probably nothing. And it's probably not nothing. That's your one chance of saving that patient's life by essentially rushing them to the IR suite and embolizing usually what is their gastroduodenal artery stump that is usually bleeding. And that's a common exam question. There are also severe functional consequences of disrupting the sympathetic and the parasympathetic plexus that are surround the SMA. These patients get a lot of gastrointestinal issues with chronic diarrhea, and their quality of life is very poor. These resections, whenever they're entertained, the arterial reconstructions, resections and reconstructions for pancreatic adenocarcinoma should always be considered in the context of neoadjuvant chemotherapy, right? This is a patient who's had neoadjuvant chemotherapy, who's been stable or improving. you're never just going to upfront do an SMA resection or upfront do a common hepatic artery resection. Right now, as we saw in the intergroup definition, resections of short segments of the common hepatic artery are considered borderline resectable, not unresectable, although they do increase the morbidity, of course. Okay, let's talk a little bit what happens after the Whipple, or after whatever surgery they've had, as we said. So that patient has had their surgery, they've recovered uneventfully. What should happen next? They should get 5-FU and chemoradiation, 5-FU leucovorin, oxaliplatin, 5-FU leucovorin, oxaliplatin, irinotecan, or gemcitabine and radiation. Okay, so you guys want to give FOLFOX essentially. And the answer is actually FOLFIRINOX. It's not FOLFOX, or I should say modified FOLFIRINOX. So there's no impact of radiation. So there's no routine role for adjuvant radiation in pancreas cancer. There may be a select role in selected patients, but overwhelmingly there is no role for radiation adjuvantly universally for pancreas cancer. So for all incomers, there are specific circumstances where you may consider it. But we know that chemotherapy improves survival. We know this from multiple trials. The question is, what chemotherapy is best? And historically, these chemotherapies used to be gemcitabine based. So if I had asked that same question, 5 or 6 or 7 years ago, the answer may have been gemcitabine, single agent gemcitabine. Today, the answer is not gemcitabine, it's FOLFIRINOX. We know this from the PRODIGE trial. FOLFIRINOX in the adjuvant setting improves survival over gemcitabine alone. Whether it improves whether it improves survival over gemcitabine with capecitabine or with gemcitabine and nab-paclitaxel is not known. We have some idea from SPAC5, which has just been released. And we have some idea from the SWOG 1505 trial. Both of these were presented at ASCO GI just last month. And it doesn't seem like there's a major difference. There's probably a bit more toxicity with FOLFIRINOX. But the standard right now is FOLFIRINOX, whether that's for neoadjuvant chemotherapy or adjuvant chemotherapy, or for metastatic pancreas cancer. The standard is FOLFIRINOX. That being said, FOLFIRINOX is a very difficult regimen to tolerate. And if you don't have the kind of functional status that allows you to get FOLFIRINOX, you typically will get a gemcitabine-based regimen. So you have a patient with a large pancreas cancer that is locally advanced. It's encasing the SMA and the celiac axis. What is going to be their treatment for this locally advanced unresectable pancreas cancer? Okay, so as I said, it's going to be FOLFIRINOX for the neoadjuvant setting, for the adjuvant setting, for the palliative setting. It's going to be FOLFIRINOX. It's going to have superiority. They're telling you that this gentleman is 45 years old, so it sounds like they should be able to tolerate FOLFIRINOX. Yeah. So the answer is FOLFIRINOX, FOLFIRINOX, FOLFIRINOX for the neoadjuvant, for the adjuvant, for the metastatic, if that patient is able to tolerate that. If they're not able to tolerate FOLFIRINOX, then you're looking at usually a gem-based chemotherapeutic regimen. That's either gem alone, Gem-Abraxane, or Gemcis, or Gemcis. Okay, 64-year-old female had a left nephrectomy 7 years ago for an RCC, and now she has a 2-centimeter hyper-enhancing lesion in the pancreatic head. What is the next best step? She should get sunitinib, she should get an EUS and biopsy, she should get an enucleation, or she should get a pancreatic oligomectomy. Yeah, I will say EUS and biopsy is not unreasonable, but what this scenario is trying to tell you is that she has a renal cell carcinoma metastases. The way that you know that that's that is because it's hyper-enhancing. So pancreatic adenocarcinoma is hypo-enhancing. It's a very hypovascular tumor. It's essentially one big scar with a lot of desmoplastic reaction. And the only hypervascular lesions you're going to find in the head of the pancreas or in the pancreas is going to be a neuroendocrine tumor, or in this patient, a renal cell carcinoma. EUS biopsy is not wrong. You could certainly get an EUS biopsy, and you probably should before you go ahead to getting a Whipple. So there are some metastatic lesions to the pancreas. They are rare, typically hyper-enhancing as opposed to the hypo-enhancing masses of adenocarcinoma of the pancreas. And renal cell carcinoma is the most common, has a specific affinity to the pancreas. There are some situations where you would consider resecting these patients, typically patients who have a long disease-free interval and then a delayed recurrence, and patients who've been stable on tyrosine kinase inhibitors such as sunitinib. There are other cancers that metastasize to the pancreas, lung cancers, specifically lobular breast cancer has a particular affinity for the pancreas, and melanoma. That's about it for today. So perhaps we can do some questions now. If you guys have questions.
Okay, well, there's a couple of questions in the Q&A. I'll just say them out loud and we can answer them. We'll go from the latest question. Diabetes type 2 is considered as a risk factor for pancreatic cancer? Is it considered as a risk factor?
No, at least not in the sense that it is causative. But what often happens is that you often have a diagnosis of type 2 diabetes that precedes the diagnosis of pancreas cancer, because you get occlusion of the pancreatic duct, you get atrophy of the pancreatic parenchyma, you become a diabetic, and so it's not uncommon for patients diagnosed with pancreas cancer to have had a recent diagnosis of type 2 diabetes. So it's not that type 2 diabetes caused their pancreas cancer, it's that they became diabetic after their pancreas cancer caused atrophy of most of their islet cells.
Okay. The next question is, when to do an endoscopic drainage for pancreatic pseudocyst, and when percutaneous or surgical drainage?
Yeah, so I mean, ideally you would drain them endoscopically if you have good apposition with the stomach and it's technically feasible. Yeah.
Okay. And the next question, why is cystic neoplasms asymptomatic, or are cystic neoplasms asymptomatic?
So I should say most cystic neoplasms are asymptomatic. Some cystic neoplasms can present with pancreatitis, specifically the IPMNs, right? The IPMNs will eventually clog up the pancreatic duct with mucus, and you can develop an episode of pancreatitis. And if you do, again, remember thinking back to the Fukuoka guidelines, a clinical episode of pancreatitis in the presence of a pancreatic cyst is a worrisome feature, because it indicates that that cyst is progressing somehow.
And the next question is, what is the indication for pancreatectomy? I think we answered that question, right?
For mucinous cysts, you mean?
No, it's a broad question. What is the indication of pancreatectomy? We can go back and look at it later on. We'll upload the lecture.
Yeah, I don't really understand that question.
The next question, will not enteral feeds produce more enzyme and hence damage the pancreas further?
Yeah, so that's a theoretical, that's what you would think theoretically, and that's what people used to believe. I think the problem is that very often we have an idea in our minds of how things work, and the reality is much more complicated than that. What is clear from high-level randomized evidence is that enteric feeding in pancreatitis improves outcomes over fasting a patient, keeping a patient quickly fasted and just giving them TPN. And the way that it does so is by preventing infectious complications. So when you don't feed the gut gets most of its nutritional supply directly from the lumen, specifically the enterocytes. And if you don't feed the enterocytes, they start losing a lot of the tight junctions. You get what's called a leaky bowel. You may have heard that in kind of the alternative literature. It's a very popular concept in kind of new age alternative health circles, but it is also like a real thing that we deal with in the ICU all the time, leaky gut. And when you get leaky gut, you get bacterial translocation. And you get bacterial translocation, you have this ready nidus of, that can be readily colonized. You have a big pancreatic necrosis that's just sitting there. It's not infected yet. You get bacterial translocation, you infect that necrosis, you get an increase in infectious complications. That's how we think that works. And that's why we think that feeding the gut is better. In a way, you have to think of the pancreatitis as already having happened. The insult is a kind of time-limited thing. Inflammatory insult is a time-limited thing. And then what you're dealing with, 3 weeks down the road, you're really no longer dealing with ongoing acute pancreatitis most of the time. Most of the time, you're dealing with sequelae of pancreatitis. You're dealing with acute necrotic collections that are going to become walled off necrosis, or an acute peripancreatic fluid collection that is going to become a pseudocyst.
The next question, can chronic pancreatitis lead to hemorrhagic pancreatitis?
It's a good question. Not in the way that I've seen, no. You can have thromboses with chronic pancreatitis. So you can have occlusive disease, yeah.
I think mainly with acute pancreatitis, we see hemorrhagic.
Yeah, so pseudoaneurysms and hemosuccus and all of these kind of arterial hemorrhagic complications are typically happening with acute pancreatitis. When you read the old textbooks, they would say some physical signs of acute pancreatitis are things like the gray sign and the Fox-Cullen sign, which are signs of like retroperitoneal hemorrhagic pancreatitis. I mean, usually if you're having that, you're having like retropancreatic hemorrhage, that patient is very much in extremis. That patient is unwell, right? Yeah.
And the next question, can acute pancreatitis complicate to chronic after treatment, or it has its own causes?
Okay, so again, there's always a lot of confusion there with both from the patient side and from the training side. You can have acute pancreatitis and then be dealing with the chronic sequelae of that. For example, you have acute pancreatitis and then you get necrosis of the neck of the pancreas. You now have a disconnected duct in the tail. The tail is still alive, the head is still alive, the neck is dead, and you have a big necrosis in between them. And you're dealing with this for months and weeks, and a drain and a cystgastrostomy, and it blocks, and you guys all taking care of these patients. So that patient does not have chronic pancreatitis. They're just dealing with sequelae, long-term sequelae of an episode of acute pancreatitis that has disrupted your gut.
Okay. Do all anatomic anomalies need intervention, or only symptomatic cases?
Yeah, almost none of them do. It is extremely rare to have to operate on someone with, for example, a pancreas divisum. Again, 10% of the people on this call have a pancreas divisum. And, I'll bet you that almost none of you have pancreatitis from your divisum. Even when you find a patient that has pancreatitis and a divisum, it is usually caused by something else, commonly alcohol and gallstones and the myriad other things that are causing that. It's excessively rare to have to operate on that for divisum. Even there, the way that you would typically manage someone who has pancreas divisum, where you think that the pancreatitis is caused by pancreas divisum, is by an endoscopic sphincterotomy. I mean, that's how we do it in 2020. We're not going to operate on these patients.
We have one last question from our resident. He's asking, is core biopsy a must for pancreatic lymphoma prior to treatment with chemotherapy?
Yes. They're not going to give them chemotherapy just on a whim. Yeah, typically you have that hematologist wants to be convinced that there is a lymphoma there. That's to characterize the lymphoma.
Perfect. I think, sorry guys if I missed any questions, but I think that's the end of the session. Dr. Jad, thank you so much. It's been a very informative lecture. We've had some good reviews here. Do you have any comments before we end the lecture?
No.
Okay. There's
back into this lecture. They had also asked me to talk about pancreatic trauma, but we were clearly not going to get around to that, and I think it was already very charged.
Yeah.
To talk about. So probably in the future, it would be best to split it to just having a session about pancreatic masses, and solid, and having a separate session for pancreatitis because it's quite a bit of ground to cover.
Agreed. Thank you guys, and thank you, Dr. Jad, again. It was very informative.
Thanks, guys.
It was a pleasure having you with us, and we'll see you guys later. Thank you.